Hello and welcome to Yodo. This video is provided in response to requests for additional information and more detailed information about Alzheimer's dementia. Some of this information is going to apply to all types of cognitive impairment, so even if Alzheimer's dementia is not the diagnosis, there is some of this information that will apply and is still going to be relevant. If you'd like to change the speed of the video, you can certainly do that by clicking on the settings button below. I know sometimes I talk a little fast and sometimes I talk a little slow, so whatever's right for you. This is an important diagnosis because of its frequency in the United States and the world population. Because of the costs associated with this disease, its diagnosis, the medications, and the care that it requires. This is also important because it's a terminal diagnosis. At the time of making this video, we do not have a prevention or cure for this disease process, and it's unavoidable progression. Alzheimer's dementia is a slow process, and it's a very insidious process. There are medications that can make this go even slower, but right now we don't have a medication or treatment available that's going to stop, reverse, or prevent the changes from this disease. This common diagnosis is devastating and costly for patients and their loved ones. Learning about the diagnosis, taking the medications, and being proactive and preparing for the changes that lie ahead is highly recommended. This disease is slow yet progressive, and it's a thief that takes memories, personality, and the cognitive executive function and skills of a person. Alzheimer's dementia is a difficult diagnosis to be informed of because of these anticipated changes. Since it is so common, many people have a loved one or in some way have been affected by this process. Over time, the challenges for care and medical expenses will increase with that unavoidable progression of this disease. The medical community is racing to find real treatments, and as they search for a cure for this terminal illness, we all have to bear witness to the changes that this disease can leave. We have reviewed some dementia basics in another video here on the channel, and I can put that link in the description box below. Now I'll provide a few specifics for Alzheimer's dementia that I get from the Alzheimer's Association. Right now, the frequency of this disease is just over 10% of Americans, nearly 1 in 9. In 2024, nearly 7 million Americans in the United States were diagnosed with Alzheimer's dementia, and that number is predicted to double in the next 25 years if a cure is not discovered. The 2023 cost of this disease was estimated at $345 billion, and that is not including all the unpaid care that is given by the 11 million Americans that are loved ones that provide care to this patient population. Next, I will give you just a few of the lengthy list of risk factors: age, mental health issues, mental stimulation, educational level, other medical conditions such as heart disease, hypertension, obesity, diabetes, and greater than 50% of patients with Down syndrome will develop Alzheimer's dementia before the end of their life. But there are also many lifestyle choices such as diet, sleep, alcohol intake, tobacco use, and social isolation that can also factor into this disease process development and its progression. One of the more well-known and feared risks of this disease is family history, specifically genetic links that have been uncovered. But this is not the primary cause for the majority of patients. Symptoms of dementia illness relate to the person's memory. There must be a memory impairment. This is an impaired ability to learn new information and an impaired recall of old or well-known information, plus one of the following: aphasia, apraxia, agnosia, and executive function disruption. Aphasia is speech difficulties, word-finding trouble, speaking and understanding words. Apraxia is difficulties with movement, the proper use of a pencil or a screwdriver, for instance. There are issues with knowing how to use a common item that ordinarily the person would know. Agnosia is the inability to recognize a common object, such as a key fob for a vehicle or a computer mouse, and those are more new inventions, but for others it might be a car key versus their mailbox key. Executive function disruption is the difficulty with planning and sequencing of events necessary for a multi-step process. This might be planning how to clean the kitchen or a bathroom, doing a load of laundry, planning a trip to the grocery store and dry cleaners, but this results in the impairment of social and occupational activities. Most patients will eventually have abnormalities in all four of these areas. New information can be obtained, but there's a separation in the ability to obtain that new information and then lay it down into long-term memory and access it. Other common features that occur can vary in the time of their development and in the severity of that issue. Suspicion of others, concerns regarding missing items, outright delusions of theft are not uncommon. And some patients will accept information from a stranger or a TV commercial, but they'll resist believing a trusted friend or relative. This group of patients are often highly susceptible to financial deception. Many patients will suffer with disruption of their self-awareness and may not recall their own actions or have an inaccurate recall of circumstances that led to a decision that they've made. And this can result in the misplacement of objects and a perceived loss of an object that they do have. Loss of objects and fear of loss can result in hoarding for some patients. A few people may hide things from others and inadvertently hide them from themselves. This inability to keep track of an item can result in agitation and worsening suspicion. It can contribute to fear being called out by loved ones that their memory is changing, and the patient may actually socially withdraw. The problem with that is it will accelerate many of these issues. Another common feature is the development of restlessness and anxiety that may be present, as well as particularly noticing this restlessness and anxiety that occur in the afternoon and early evening time. Before we get too far into Alzheimer's dementia, let's talk just a little bit about normal brain aging. For normal brain aging, even with advanced age, the brain function does allow for new information to be learned and retained. The short-term memory will embed itself into long-term memory. A normal aging brain maintains vocabulary and its general knowledge base. Cognitive slowing may occur, and this is not an indication of dementia. Reduced speed, accuracy, and efficiency of a person's ability to access information may be reduced with aging, but with normal brain function, the person continues to have the ability to access information that's established, form new memories, and learn new tasks. Elderly people without dementia have memory retention of a recent or remote event that they can access. They have satisfactory executive function. They're able to ensure their safety, make appropriate judgment, and maintain the ability to understand and respond to errors and make corrections, as well as plan and execute a proper sequence of a multi-step task. This concept is such a very important one that I really want to stress this point. The ability to prioritize and sequence multiple steps to complete a larger task is a big part of executive function of the brain. This ability will become compromised progressively over time with someone that has cognitive impairment. This can be a really subtle change, but it's a very important one. Did your relative have a great recipe, and now when they make that dish for the meal, the result is not as it should be? Some ingredient was left out, or the process of assembly is out of order, or they simply just don't make it anymore. Another example is that the person used to have a tidy garage and they took pride in their yard, and these things are no longer as they once were, and that's not due to a physical change, that their tools are out of order or their automotive maintenance is not kept up to date. Their once beautiful lawn or garden appears to be untended. Alzheimer's dementia does not typically affect physical strength, but affects the ability to think out the process of how to, in a thorough and complete fashion, the same way that the person used to have for completing that task. Many of these symptoms may seem vague or general, but they're not. What these symptoms are is they're very individual. The information of the person is changing, and therefore their daily activity and their success with a task to be completed is decreased. Adding to the discounting of symptoms, anyone can have a bad day or sometimes struggle with a complex task. So how is this diagnosis made? The evaluation for this disease process begins with obtaining a history. There are multiple tests that need to be done. The circumstances of change occurring that are learned from gathering the history are crucial in that first step. Next, we need to find the exam and the preliminary screening lab tests to be done, because that's going to guide the clinician to the next part of the evaluation. There are now numerous lab tests that are available. Some of these will rule out other causes for the memory change. There are a few lab tests now available to help us confirm some of the subtypes of Alzheimer's dementia. Yes, there's more than one subtype of Alzheimer's dementia. At this time, there is not one singular test that establishes the diagnosis, but this is likely to change very soon because of the research that's being put into this. Finally, brain imaging is often ordered. It's a good starting place to get a CAT scan, but some circumstances will lead the clinician to start with an MRI. Most insurance companies have a lengthy process before one of these newer specialty PET scans will be approved. Genetic testing may be ordered, and there are some newer tests that may require more invasive specimen gathering techniques, such as a spinal tap, because these are going to search for specific biomarkers in the spinal fluid. Now for a bit of discussion regarding obtaining a history and the cognitive evaluations. A collaborative source that knows the patient well is a required part of this history. The loved ones that come with the patient must be able to describe the symptoms with that clinician that's doing the evaluation. The provider will ask many questions and likely will ask questions separately of the patient and the collaborative source so that the information can be compared. This will then lead to the next part of the evaluation, and that's going to be the cognitive tests. I need to stop for a sidebar of information before talking about these cognitive tests. One of the issues that clinicians bear in mind is that these screening tests can have high rates of misleading findings in patients with mental health issues. A few of the more common diagnoses that can be confused with Alzheimer's dementia are delirium, fatigue, medications, and any one of a number of mental health issues. Any of these can mask the symptoms and delay the diagnosis being made properly. Anxiety, depression, bipolar, or schizophrenia are very common interference with these cognitive tests. The physicians doing the evaluation are very aware of this issue, and they take extra steps to ensure these are not being confused and that one of these mental health issues or one of these other causes is not resulting in this look like a picture of Alzheimer's dementia when it's really not. There are several different testing forms available for the evaluation of cognition. These screening tests can seem a bit ambiguous and nonspecific, but to a well-trained clinician, the results of this testing will lead them to the next step in the evaluation. When history and these cognitive evaluations are abnormal, it does substantiate the need for further testing. Now let's talk about some of these cognitive tests. A few of the more common screening cognitive evaluations are the clock draw, MMSE, SLUMS, short blast, and the MoCA. The clock draw is a common first screening test that is rapid to administer. This test only has 4 points. 1 point for the circle, 1 point for the numbers being placed on the clock, 1 for the hands, and then the last point is for the hands being placed at the designated time that is given by the evaluator. To receive credit for each one of the 4 points, the information has to be complete and correct. So all 12 numbers have to be on the clock, both hands have to be on the clock. One hand should be longer than the other hand, so it really is detailed information for only 4 points. But it's a rapid test. I'm not sure how much longer this is going to be a valid test because of the use of digital clock as opposed to analog. MMSE, or Mini Mental Status Exam, is also known as the Folstein test. Although not diagnostic, and it does have cultural bias, it is acceptable and a widely used tool that detects various cognitive issues. This test is quite sensitive to detect memory issues, but it's not specific to diagnose Alzheimer's dementia. It takes about 10 minutes to administer. It tests memory, attention, orientation, and language. It does have a copyright on it with payment requested for its use, and that may limit its administration. St. Louis University Mental Status Exam is also known as the SLUMS, S-L-U-M-S, and it's free to use. It assesses memory, attention, orientation, and executive function. It's acceptable as a repeatable test, and it's widely used to assess cognitive function. This exam has 11 questions with a total of 30 points, and it takes just under 10 minutes for most people to complete. The short blast test is a very brief cognitive screening tool that takes less than 10 minutes to administer. It's another good starting place for patient evaluation. This test consists of 6 weighted questions to evaluate a person's ability to recall known information, navigate time and space, as well as maintain attention and focus. It's a screening tool, and as such, they're not used as diagnostic tools. Another screening test is the MoCA, or Montreal cognitive assessment, and it's a 30-point test that evaluates for mild cognitive impairment. Training of the provider that is administering the evaluation is required for the MOCA. It is a paper-based test for memory, language, attention, visual spatial skills, concentration, and executive function. This test takes just over 10 minutes for the evaluator to administer. This test allows for an adjusted score based on the patient's educational level. The criteria for Alzheimer's dementia include findings across 6 domains: complex attention, executive function, learning and memory, language, perceptual motor skills, and social cognition. Along with these domains, there is disruption of the person's ability for successful completion of activities of daily living and their IADL, their instrumental activities of daily living. As Alzheimer's dementia advances, the ADL and the IADL are also interfered with. Most importantly, with Alzheimer's dementia, the symptoms cannot be caused by depression or delirium. That being said, many patients with a dementing illness do have depression or anxiety or both related to their memory decline. Also, patients with a history of depression are at a higher risk to develop Alzheimer's dementia. Regarding delirium, many patients with dementia at nearly any stage can easily develop delirium, more so easily than a person without a cognitive impairment issue. This patient population has a lower threshold for developing acute delirium. An infection can occur and result in another serious medical event, but that will stimulate delirium to occur. Delirium is common to occur in patients with dementia that are admitted to a hospital. I would encourage loved ones to rally their forces and try to spend as much time staying with the patient, particularly evening and night hours, if they have a cognitive impairment issue because of the risk for development of delirium. The development of delirium can have a profound adverse effect on any patient, and those with a dementing illness are at significant risk for this to result in more rapid decline of cognition and result in a newer, lower baseline for their cognitive level. A cognitive level that drops may not recover to that prior level. I don't want to dive any deeper into the tangled web of these differential diagnoses or this delirium conundrum right now. There is a separate video on the channel that does discuss that. Because these issues are so common, most treatment protocols include medications that are going to address these issues. Now for the progression of the disease discussion. The progression of Alzheimer's disease is slow, and sometimes it's so slow that the loved ones that are with them may totally miss some of the early warning signs. Circumstance can also be a terrible contributor to missing some of the early warning signs. When families are physically not near the patient, they may miss some of those early warning signs. If the patient has lived alone or is independent and has few visitors, or when others, out of respect for an individual's privacy, they're not actively or intimately involved in that person's life, those subtle symptoms can be overlooked. For others, the circumstance may be that the person has always been more passive or quiet, and thus these subtleties and changes are not caught until the disease is more advanced. Alzheimer's disease does follow a particular pattern of progression. The FAST tool, developed by Dr. Barry Reisberg, outlines the 7 stages of functional decline. This functional assessment staging tool, or FAST, breaks the decline pattern into groups. Alzheimer's follows this typical pattern. However, many of the other causes of cognitive impairment do not follow that typical pattern. The FAST scale does communicate to a reader of a medical record or chart regarding the severity of a patient's cognitive impairment for any patient with any dementia, but it doesn't speak to the anticipated pattern or speed of that decline unless that patient does have the diagnosis of Alzheimer's dementia. The FAST scale is not part of these stages that we're going to discuss in the next video. This was the first part of a series on Alzheimer's dementia. The next video will break down the 4 stages. To live with progressive Alzheimer's dementia is heartbreaking for the patient as well as their loved ones. Certainly it is difficult to hear about each and every one of the various diagnoses of cognitive impairment, but as Alzheimer's dementia is so very common and it touches nearly all of us in some way. Alzheimer's disease leads to permanent changes in memory, personality, and function. That it's currently a terminal disease process without a cure, it is worthy of time to talk about it openly. Patients and families find that when preparations that are necessary have been addressed earlier, their burdens are lessened. Knowledge is power. When caring for someone with memory impairment, it is important to follow some guidelines, and these are reviewed in the channel on another video, and I can link that for you below as well. Early diagnosis and treatment initiation are key parts in maintaining function for a longer period of time. Check back, as the next videos will discuss the various stages of Alzheimer's disease. If there is other information that you would like to hear about, please let me know in the comments below. I appreciate the thumbs up on these videos that you all have been leaving. Bye now.